Today I'll be explaining you regarding a surgery that is decompressive craniectomy plus duroplasty, which is a very common neurosurgical procedure that we do day in and day out. So brain is in a closed compartment. Inside brain and outside it is covered by skull. Anything extra inside the brain, be it bleed, be it swelling, tumor, infection, it will lead to pressure inside the brain. To some extent, the brain can compensate, beyond which it does not have the capacity to compensate, and it will lead to damage to major structures, important structures inside the brain. The most important structures that is at risk of damage and is life-threatening to the patient is the brainstem, which is a butterfly-like structures in the middle of the brain, which is responsible for controlling BP, pulse, consciousness, hand movements. If at all there is any pressure to the brainstem, then the patient might actually die. The patient might actually land into brain death also. So, the primary aim whenever there is increased pressure in the brain is to relieve that pressure and protect the brainstem, as well as secondarily also protect the other vital structures in the brain, improve blood flow and allow the brain to recover. So what is decompressive craniectomy? Herein, any patient with bleed, trauma, tumor, infection, the part of the bone flap is removed and it is preserved either in the abdominal pocket or in the bone bank for future use. Decompressive craniectomy and duroplasty is done in patients. It is an emergency surgery that can be needed in patients at any point of time. So what all conditions can lead to the need for this surgery? First is trauma. Any road traffic accident with any major bleed on one side of the brain can develop the need for decompressive craniectomy. When the patient's sensorium is low, there is pupillary anisocoria. That means the reaction of the pupils is different or there are any hemodynamic fluctuations. Second, decompressive craniectomy can be needed in patients with a large bleed, sudden spontaneous hypertensive bleed, or because of some aneurysmal rupture. The bleed will be putting pressure and compress the brainstem, and it might need removal of the bone flap and very rarely, if approachable, blood clot evacuation. Third, it can be needed in patients with stroke. Stroke means thrombosis or blockage of one of the blood vessels of the brain, due to which the brain is not getting enough blood supply and the cells of the brain, they start dying, which is known as ischemia, followed by permanent damage, which is known as infarct. Whenever this happens, the cells, they release some materials which lead to swelling of the brain and increased pressure in the brain. This can also lead to the need for decompressive craniectomy. In some sort of infections, abscesses, tumors, wherein they are very big in size and causing a lot of swelling in the brain, in such cases also decompressive craniectomy can be required. Post any tumor surgery, when there is sudden bleed in the brain, then also we might have to immediately rush the patient to decompressive craniectomy and duroplasty. So basically it is an emergency procedure in which we immediately shift the patient to OT after all pre-anesthetic workup and fitnesses, and we put the patient on general anesthesia if not already tubed. Mostly such patients, they will be already placed on ventilator support to decrease the pressure in the brain and also to protect the airways, since they will not be good in sensorium. To maintain the urine output and to monitor the urine output, the Foley's catheterization will also be done. Head shape will be done, and after lifting one part of the skin flap, we will be putting burr holes and removing one part of the bone. That bone, depending on the condition, we can either preserve in the abdominal pouch or we can also preserve in the bone bank, depending on the patient condition, surgeon's need and preference. Once the bone flap is removed, there is a covering over the brain which is known as dura. That dura has to be cut to release the brain of the pressure, and duroplasty is done wherein different materials are used like G-graft, Duragen to cover the existing defect, because that dura inside contains the brain fluid which is known as CSF, cerebrospinal fluid, which has high chances of leaking out post-surgery. The soft Duragen or the soft G-graft allows in good expansion of the brain and relieving pressure inside the brain, which protects the brainstem. So post the decompressive craniectomy surgery, the patients are usually kept completely sedated and on ventilator till 24 hours. After the 24 hours, we plan to repeat one CT scan, and if there is good expansion of brain, then we plan to stop sedation and further checking the sensorium of the patient. Please remember, this surgery is only a life-saving measure for the patient to relieve pressure from the brain. It does not guarantee how the patient will improve further. The already bleed, clot, tumor or trauma might have caused a lot of damage to important areas of the brain, which might be permanent damage also. So even after the surgery, even after recovery and survival, the patient can have permanent neurological deficits in spite of all efforts, because this surgery is only to relieve pressure from the brain. Post-surgery, once the patient is slowly coming out, if the sensorium improves and we are able to get the patient out of ventilator support, then extubation, that is getting the patient out of tube, is planned. Even in 2-3 days, if we are not able to get the patient out of ventilator support, then to safeguard the airway, we do another surgery which is known as tracheostomy, wherein we remove this tube, bypass the tract, put a hole in the neck and a tube directly into the lungs, and slowly get the patient out of ventilator support from big ventilator to small ventilator. Definitely, the surgery itself also bears some sort of complications like bleeding risk, rebleeding. If rebleeding happens, it might lead to compression into the brain and sudden deterioration of the patient. Infection, wound healing issues, delayed wound healing, leak of the cerebrospinal fluid from the wound and need for resuturing, brain infection which is known as meningitis, decline in cardiac parameters, decline in kidney parameters, lung infection, aspiration, urine infection. Because the patient has so many tubes into the body, there are always chances of multiple infections that the patient can have. There are also chances of sudden brain death and sudden cardiac arrest, and if there is a lot of pressure in the brain, sudden on-table death can also occur. These patients who have a huge bleed, trauma, infection or tumor in the brain, they might be bedridden for a long period of time. If the bleed or the pathology is in the dominant lobe of the brain, then the patient might have speech issues also with respect to not understanding, speech issues with respect to comprehension as well as speaking. The patient can also have one side of paralysis which might be permanent. There are high chances of development of seizures. Usually we have a protocol of giving seizure prophylaxis to prevent any sort of seizures in the patient and also give medications to decrease the swelling in the brain. But in spite of giving multiple seizure medications, patient can still develop seizures. How many days the patient will stay in ICU, how many days it will take for the patient to come out, there is no guarantee in such kind of severe head injury or head trauma cases. Post-discharge, once the patient is stable, the patient might have to go to a rehabilitation center because the patient might not be fully conscious, might be bedridden, might have a lot of infection, might not be able to do his normal work like other patients, and might also require lifelong support and care. Tracheostomy care, bed sore care, infection care, wound site care, all these things might be required when the patient is in rehabilitation center, and there can also be development of secondary issues like multiple bleeds, multiple strokes, heart issues, lung issues. Sometimes the clot in the leg veins can go up and cause something which is known as pulmonary thromboembolism also. So the patient can have varying courses. If the patient is stable and he recovers all these things, then after 2 to 3 months, when the brain swelling comes down, we can plan for cranioplasty, that is replacing the bone flap back. It is purely a cosmetic procedure and there is no chances of any neurological improvement when doing cranioplasty. One more complication that might come with any change in dynamics in the brain with respect to bleed, trauma or tumor is sudden blockage in the drainage system of the brain. Sudden blockage in the ventricle system of the brain that can lead to sudden increase in water in the brain, which is known as hydrocephalus, and in the future the patient might require a shunt for it. So overall, any patient who has undergone decompressive craniectomy can have varying kinds of prognosis depending what the primary pathology was. As a neurosurgeon, what we can do is try to relieve the pressure in the brain and try to save the life of the patient as much as possible. But still, it is a subject of multi-speciality where multiple teams like pulmonology, neurology, critical care team, cardiology, if it is a trauma case and if patient has suffered multiple fractures or any other issues with respect to soft tissue injury, kidney injury, then other specialists like orthopedic, urology, gastroenterology might also have to be involved, and accordingly the patient might have to be managed. So varying patients can have varying sorts of prognosis, and in spite of doing all, the patient can develop multiple infections and the patient can also die. All the complications that I told are the most common complications that can develop in 1 to 5 to 10% of cases. But apart from these, there are 1% chances of development of any unforeseen circumstances or any unforeseen complications that are not in our hand, that are beyond our control, which have not been mentioned here.